Now we're going to roll up our sleeves, so to speak, and we're going to get into our panel discussions. We've got a couple of them back to back. You may find these panel discussions even merging and coming together at some point here today. This is a slightly different format for us, and the main purpose is for us to get a chance to explore and hear unvarnished reactions from what people are experiencing on this topic. So to take us through these next segments, it is my tremendous pleasure to pass the baton back to my friend Oyinda Osibanjo, who's going to be moderating these panel discussions. Oyinda, thank you, my friend.
Thank you, Paul. It's always nice to tag team with you, Paul. And I'm so excited to be here with everyone again. And this time we're going to have a conversation. And I do have some amazing people that are going to help us with this. The goal here is to have a member voice as we have this conversation. Like you said, I presented initially. I have Dr. Guillaume and Sharetta presenting, and then I have Dr. Uche presenting. But we want to hear the member perspective because that is the key aspect. Everything we're doing here today as healthcare provider is to serve our members. So I'm going to invite Amanda, I'm going to invite Leslie and Sharetta to this conversation, and I want them to introduce themselves. Thank you, Amanda. I also do have Sharetta and Leslie on this call to have this conversation. And what I'm going to do first is that I'm going to allow them introduce themselves so you get an understanding of their backgrounds, where they're coming from, and then we're going to go into the conversation. And remember, it's organic. I want you not to hold back. We are helping each other. And when people can understand the challenges, then they can make changes. Then we can support our members appropriately and patients appropriately. So I'm going to go Amanda, Leslie, and Sharetta. And Sharetta, I know you already presented, but please give it to us again. So Amanda, please go ahead.
Good morning. It's good to be here. I didn't realize so many people were going to be on this call, so this is a surprise. My pronouns are she, her, ella. I am a community health worker, and I also support our community health workers, which is a huge journey and job, but I love it. I have experience in the FQHC world, so Federally Qualified Health Center, as a community health worker working with primarily farm workers and also patients who are Spanish speaking. Currently, I work for Familias en Acción, a small nonprofit based in Portland, but we serve statewide. I kind of help support our COVID-19 wraparound assistance program. And then we also do general resource navigation for folks in the community who need it. And helping support people access medication is definitely a piece of that. So I think that's it.
Thank you, Amanda. Amazing. Thank you so much. Leslie.
Good morning, everybody. My name is Leslie Asinga. I also am a community health worker or community health specialist, which is what Multnomah County likes to give us as a title. I am one of the first cohorts of community health workers that were folded into the medical model for Multnomah County. I've been doing this going on 8 years now. It's been a very interesting ride in terms of folks really understanding what it is that we do and how we do what we do. So sometimes we're like smoke and we make things happen, and the doctors are in awe of the things that we're able to do and accomplish in the ways that we are, the way that we listen to patients, the way that we lean in, the way that we're able to help and facilitate, the way that we're able to provide providers with additional information that they didn't know about patients. So it's very rewarding work, but it's also very taxing work. But the payoff is you see people getting the care that they need. And that's why I do what I do.
Thank you so much, Leslie. And Sharetta.
Yes, I'm Sharetta Butcher. I work for North by Northeast Community Health Center, and yes, as a community health worker, um, my role has changed here at the clinic, but as a community health worker, it never changes. especially being a part of the community. Like here in Northeast Portland, you become a community health worker for not just the clinic, but you come for the community. And so once somebody has your name, you become that person that a lot of folks come and call on. So yes,
Thank
I'll
you
be
so much.
talking for the community.
Yes, thank you. And so the first question I want to ask you is I want you to share with me those unique challenges that you've seen with our culturally diverse population. And I know there's so many, but I want you to give me those challenges that you see that we as healthcare providers, I'm a pharmacist, that we cannot even understand that comes from your view of having that experience with them. And so I just want you to share those challenges that you've had with your patients and how you've supported them. So just highlighting it for us. Amanda, you can go first, and then Leslie and Sharetta.
Yeah, I think there's challenges, like even when folks have insurance, and then there's an added barrier when folks don't have insurance. And so that was the majority of kind of the situations that as a community health worker I worked in. So there was an assumption that if a medication was prescribed, that the person was going to be able to get it. And that definitely was not the case. And so I think the countless hours community health workers at our clinic spent trying to find something that was even like remotely affordable for folks that didn't have insurance, folks who were on, just the emergency insurance through OHP. And especially with insulin, that was like one of the biggest barriers, was finding insulin that was affordable. And so and then from once you found it, it was like, then the challenges of like, were all the right questions asked? Maybe this person was scheduled a med rec, but then their daughter or son didn't show up with them. And so lots of things were missed, I think. So I would say that's kind of where I was at. I think just even finding the medication was like the biggest challenge. And then I think going through a lot of the things people have talked about, which was like making sure if the pharmacy was close to their house, getting a med rec scheduled, getting the instructions actually in the language they speak. So I think affordability is probably the primary thing, and then going back to the health literacy piece.
Leslie, thank you so much, Amanda. I appreciate that.
I would say the elephant in a lot of people's lives are the social determinants of health and how far-reaching that really is in terms of health outcomes. Folks have things, as my friend used to say, stacked up like dirty clothes in terms of how much they're dealing with in their day-to-day existence. And the stress that comes with that mind-body connection, and how that stress just whittles away at all of the bodily systems, in spite of efforts, if there's not more equity in addressing the social determinants of health, getting on top of health is going to be next to impossible, honestly. I think one of the biggest challenges when you start to talk about medications for the patients that I assist or I have assisted, it's around people understanding why this medication was prescribed. And when they're taking, because I deal with a lot of patients that have layered chronic health conditions, and they're taking fistfuls of medication. And they're like, well, what is this for? And what is this for? And what is this for? So nobody's really, because it's so much, and you can only be present for so long, and you're really talking a language that people don't necessarily understand. That repetition is very important for them to begin to understand, no, these medications address your hypertension. This medication is for, for the edema. this medication is for, and that part just does not sink in with folks in a way that makes them understand why they're taking all the meds that they're taking. I think the other thing that sometimes is remiss is that patients don't get enough information on the side effects of medication. So after they take a med and they start to feel some kind of way that makes them out of sorts, or they don't really know how to explain because they don't really know what to expect with the medications that have been prescribed. And so they may call me and say, Leslie, this medication makes me feel really, really dizzy, or they may say, it's not working. I've been taking it as the doctor says, but it's not working. It's that kind of stuff, and helping people to understand that there are different kinds of meds. Just because you're prescribed one medication, it doesn't mean you're stuck with that medication, but there's a whole tree, and that's what I like to call it, of different medications that can be prescribed for your condition. And a lot of it, because everybody is so individualized, it's trial and error. So just because this one thing works for you or did not work for you, it can be adjusted. And so that's also part of the education that has to go on, I think, with patients quite often. The other part is around people not knowing the medications that they take. Sharetta kind of alluded to that when she was saying, it's that purple pill. And we're having a phone conversation, and pharmacology is not my thing. So I don't know what that purple pill is, and they'll try to describe it to me. And then, but to actually begin to know the name, or to even spell the name correctly, I said, even if you just stab at it a little bit, I might get an idea of what you may be talking about in terms of what the medication is. So it's all of those things and then some. It's forgetting to take meds. It is the whole premise of folks that are new to the country, white man's medicine. I'm not taking white man's medicine. I didn't have this issue before I got to the United States. Why am I being pumped full of all these pills? I've never taken pills like this before. And not understanding that you're in a different culture, you're dealing with different things, you're eating differently, you're exercising differently, you're moving differently, your stressors are different. All of those things, whittle away at your health. And so that part is a part of understanding also what moving to the United States looks like and feels like, and the effects that it can have on your health.
Thank you. Thank you, Leslie. Thank you, Amanda. Sharetta.
Yeah, Amanda and Leslie hit on a bunch of mine already, but just a couple of things that I think that challenges that I have heard, like some of the like with folks who have like asthma, that the emergency inhaler is cheaper than the daily maintenance inhaler, which makes no sense. But so they will use the emergency inhaler because it's cheaper. And I don't know what effect that will have on their bodies, but that daily inhaler to me should be cheaper because you need to use it every day than the emergency one. And the cost of those are ridiculously high. And so folks are not using the medicine correctly because their doctor's prescribing the daily inhalers for their asthma, but yet they only can afford the emergency one. So that's the one that they use on a daily basis. Doesn't make sense. The cost, so cost has a big effect on how folks are using their medications. We do try to do some over-the-counter stuff and keep it here, but a lot of times, we don't have everything here and can't buy everything for everyone. So, that plays a big important. We have some patients that are uninsured, that struggle with their meds each month because they're uninsured. And then the different programs that are out there that are supposed to be helping uninsured folks with their meds is costly for
Mm,
us to be able to refer them to those programs. So it's, it's like I don't know, it's just confusing to me. And it's making the gap even bigger for
mm.
folks of color who needs to access those places, and where those dollars are going for those folks to be able to take advantage of that.
Okay. Sharetta, are you done? I don't want to interrupt you.
Yeah, I'm done. I'm done. I said they had said everything else, so I don't want to repeat everything because Leslie and Amanda definitely know exactly. Um,
Yeah.
we're dealing with the same issues. Yeah.
Yeah. Yeah. And I really want to appreciate the fact that even as you spoke, I had that passion. And one thing that you kept on saying affordability, and it's kind of a thread along each conversation. That social determinants of health. It still comes back to, you know, income, being able to afford your medications. If you cannot eat and have your daily meals, you're not going to think about your medications. So even though you're saying social determinants of health and there's still other many factors, it still comes back to that affordability cost. And I really do appreciate what you are all saying. And I really want to ask you, and I want you to step back and I want you to be down to earth and real with me. Do you think, as community healthcare providers, do you think that you are actually empowered and you have those tools to support your members, or you, as even as community health workers, as you are representing the voice for patients and our members for CareOregon in this case, do you think you have the tools to support them, or like Sharetta said, there's so much confusion even in accessing support? Just wanted to shed some light on that, and that, do you have those resources? And Amanda, you can start. Just go that cycle.
Oh gosh, I feel like that's the question of the day for everything. I think there are some resources. Do I think they could be better? Yeah. I think there's often, like, if there is a resource, there's also often like a huge delay for it to be like translated. And then it gets updated, and then it takes another 2 months to get it translated. It's like this like back and forth of like, if a resource becomes available, then it's like, is it available for the community that I work with? Maybe, maybe not. I think it gets really challenging when like a lot of assumptions are made of whether or not even somebody needs a resource. I think so often, like, if a patient doesn't have insurance, the provider will be like, okay, putting your prescription through, it's at your pharmacy, here's a good RX card. And then that's the resource. And without having asked like a lot of really important questions. Or if interpreter's in the room, the interpreter's trying to like wrap up some really complex things that they talked about that an appointment, and then the questions around like if this person's going to even be able to access their medication just get like thrown out the door because there's not enough time. And so I think there's a lot of challenges. I think, are there resources being created? And I think yes, but I think, is it good enough? I would say no. So I think I'm always hopeful that there'll be more advocacy at all levels, not just at a community health worker level, that the advocacy won't just be up to the community health worker. That'll be from all points in a healthcare system. And two, that it won't be all on the community health worker, that'll be like this integrative approach, which I think is like the most beautiful way to care for somebody, is that you've got a community health worker advocating, the provider advocating, a social worker maybe even advocating, the behavioral health person maybe also even advocating. You have all these levels, so that it's more balanced and all the right questions are being asked, because it can't all be left up to one person.
All right. Thank you so much. Yeah. I think Leslie, what are your
So
thoughts?
when you talk about resources, are you talking about resources general? When you ask about resources, or are you talking about resources specific?
So either way works for me, and I don't want to keep you in a box, because you are in there's a space and there's so many other resources I might not even be aware of. So I'm open to learning from you. So
Okay.
if you want to be specific, that's fine with me. If you want to be general, that's also okay. But I want to come from your perspective, your day-to-day work, and what are those unique challenges in terms of resources?
So the biggest resource that's lacking right now is affordable housing. I'm going to go even once I'm talking about low income housing, not affordable housing, because that's a whole different strata of housing. The other challenge that we deal with often is around mental health. And when you start to talk about engaging with a person who has mental health conditions, it's can be totally, when they're not medically adherent, it can be totally and completely different. And it's very challenging. It's very, very challenging. And there's not enough supports in the systems for people that have mental health conditions, period. There just aren't enough. There's not enough in reach for folks who have addictions. You see the uptick of the addictions, not just within the homeless population, which a lot of people would assume, but just within the general population. And what does that support look like as a person starts to move through the stages of change to readiness to sobriety? That could be potentially a very long road. And who's there along each step? Because that doesn't happen like that. It's an in and out, it's an ebb and flow. I'm ready today, but I might relapse tomorrow. And the same way with mental health. Somebody can, say, for instance, go into Unity, they come out and they're percolating, because they're on their medications and everything has some level of equilibrium. And then they stop taking their medication again, or they go into homelessness again. Another social determinant of health. The other challenge is in-home healthcare workers, for folks that, when you talk about mental health, when you talk about dementia, or you start to talk about memory loss, and people who aren't able to manage their lives because they don't qualify for an in-home healthcare worker the way the system is currently designed. And there's so many people that need in-home health workers because of mental, memory issues, or because of, maybe they have sciatica really bad, or, there's so many things that you don't have to be chronic, but it's enough to impede your life or your ADLs in a way that you still need that in-home assistance. And many folks don't have family to help support them. When we're talking about our elderly folks, there's a lot of loneliness that's out there, and a lot of people that are, living by themselves that don't have any supports around them. And then I become that person. I become, calling me just to talk, calling me because they have a question, calling me for so many different reasons. I manage a lot of people's lives in the role that I'm in. And that's the taxing part, because it's not just the medical part. It's every single facet of people's lives. And that's not just the patient, that's everybody under the roof. Because of the the connectivity that's happening. If it's a family unit, you're dealing with mom, but you may also be dealing with the children at the same time, or the husband, or the boyfriend, or the grandma, or whomever's under that roof, or whoever that patient is engaging with. So it's a much bigger circle than just the person that's in front of you. And that's the life of a community health worker. And you may go in for one thing, but when you start to unpack, then you start to see, oh, what we're going to do, we have to deal with this too, because this is going to get in the way of the, and it becomes putting a jigsaw puzzle together, right? I can't get here until I deal with this. And because all of our work is referral driven, you start out with this, the patient's not medically adherent, or the child's not coming in for a well child check. And then you go into the home And you're like, whoa. So you're not going to get here unless you deal with all of this. This is just what's above surface. This is all the stuff that's happening down below that you're never going to get here if this stuff isn't addressed. And those are the real challenges. And we deal with so much of that on a daily basis. And it's easier said than done.
Yeah. Wow. I was taking notes. I had to stop because this is deep. Sharetta, please go ahead. Yeah.
So you talking about some of the resources, and so some of the programs, like, do we have the tools that we need? And the answer would be no. I don't. I think we don't. I think some of the programs, some of the things that Amanda had alluded to, we get, you hear about a program and you get a couple people enrolled in it, and then the funds dry up, or they're gone, and then, or they're in it for a year. So like, oh great, there's a program over here for folks that are uninsured that can get some health care, some assistance, and then after the year is over, they're back, without it, and still not eligible for the Oregon Health Plan. And so then you're they come back to you because you were the one that you helped them before. So they come back to you because they're like, okay, what do I do now? And so then here you trying to help them, trying to figure out what to do, for their health care. And it does, like Leslie was saying, it does get taxing because you feel there's an obligation, that it's a relationship that now, and I said that, and we talked about that in our presentation. When you are working with people, you develop a relationship with them. It's not just a little relationship that you just to get by. It's not that. When you develop a relationship with a person, you have a relationship with them, and that's it. And it's just like you having a relationship with your neighbor, or your best friend, or a family member, and it becomes like that. It becomes just like that. So they come back to you, and they may not know anything else, but if Sharetta's gonna be there, call Sharetta. She's gonna help. And that's what starts happening. And then you have to start figuring out how to make this work. So I'm back helping another patient who does not have health care right now, and trying to help her figure out what to do with her medication that she needs. And that becomes like, well, she's not a patient of North by Northeast anymore, but we have this relationship with her now. She was a past patient. So how do you work that out? So no, we don't have the tools that we need to really help people. I would love for CareOregon to figure out some resources to help that. More money, yeah, more money. More designated money, yeah, more designated money. I'm telling you, you want to be real, yeah. Let's put the money there. We need the money to make things happen for those folks. I don't know what else to ask for. I don't know, but if there's a pharmaceutical program, something I think would help. But the social determinants that Leslie was talking about, that stuff is real, and people are here. They're present. They're in our face. So they're not going to go away.
Yeah,
so we need to figure out how we need to help.
Yeah. Thank you so much, Sharetta. I'm on a time check. Paul, we're going to be adding on our other panelists, but I really want to say something. I really want to say this, that it's important that we as healthcare workers, as we're here, know that there's that important space for our community health workers to be that voice, to speak on their behalf. And that is what we're doing currently. And I had so many other questions. I'm going to try to throw it in as we have other panelists joining, which are our pharmacist, health resilience specialist. We do have Amy, we do have Marina joining us, so we can have also the perspective of our clinicians. And one of the things I want, as they join, please join us, and you can unmute and join with your video if you are able to. No pressure. So, but as we wait on them to join us, and they'll be introducing themselves as well, is one of the things I want you to think about is we as healthcare workers are here. Welcome, Amy. And one of the things I want you to start percolating, because I'm going to ask you in the next few questions, is what are those assumptions that you see happen? And I think you mentioned it, but I want us to be very specific that we assume about culturally diverse populations that when they come in, they can't tell their provider, but they share with you. You can just have it, just one example, very concrete one, but percolate about it and prepare yourself, because I'll ask, because it's important that we hear what we cannot hear from our patients directly, because they can open up to you and they feel more comfortable. And sometimes they feel less intimidated, but they can talk to you because they feel you have a relationship with them and you get them. And so that is the idea here, to help us understand what are we missing and how can we improve and care for our patients. Welcome, Amy. I really appreciate you being here. Please introduce yourself. And I also know Marina is on the call. I do not see you, Marina, but if you are able to unmute and introduce yourself after Amy, that would be awesome. Welcome, Marina. Thank you so much. Amy, please introduce yourself, and then next, Marina.
Hi, my name is Amy Servan. I'm a pharmacist and the director of pharmacy at Road Community Health. We are a FQHC, and we currently have 2 340B pharmacies embedded within our clinics. We kind of have a semi-diverse. We are Southern Oregon, so we have a semi-diverse population down here. We do have a high percentage of patients that speak Spanish, as well as a lot of patients that are in and out of transitional housing. We still have a lot of the patients from the fires that are, I think it's been addressed, dealing with housing issues and those types of things. And so that's kind of the population that we are currently serving.
Thank you so much, Amy, for being here. We really appreciate your presence. And I'm going to get to you in the next few minutes after Marina introduces herself.
Good morning. My name is Marina Brink, and I'm a health resilience specialist at Meade County Health Department. I predominantly serve the refugee and immigrant population.
Awesome. Awesome. Thank you so much for joining us. And I'm going to give Amanda, Leslie a bit of and Sharetta a slight break, just a break, percolating break, while I turn to Amy and Marina. And I want to throw a similar question. And you see, the perspective will be slightly different because you're coming from a clinician's perspective. And I want to understand some of the specific challenges you're seeing with your culturally diverse population that we as healthcare providers should be hearing, should be addressing, that we're missing. And I want to hear it from your perspective, and I want it undiluted, just straight to us so that we're real and we can learn from each other. And so I'm going to ask you, Amy, to go first, and then Marina.
I think a lot of it's been talked about. I think for us, the communication and the barriers there with communications for our patients. In the pharmacy, there's been a lot of strides as far as having, certified interpreters to be present when we're trying to explain medications to patients, dual languages on labels and those types of things. What we're finding is, one, there's just not enough interpreters to help us translate or to help us explain the medications. And I think one of the biggest things we've had is we have our phone interpreters, but to sit there and try to explain to a patient how to inject their insulin and then have somebody over the phone translate and try to mimic what you think they're saying and show them how to do it and try to do a teach back with a patient. It's a real struggle. Some of the other things that we're facing on access for our patients for their medications is that a lot of the specialty drugs like Hep C meds and stuff are requiring mail order prescriptions and specialty pharmacy mail orders. And a lot of these patients have rotating addresses, or they don't have accessibility to have a safe place for their prescriptions to even be mailed to. So we find that we're really struggling with that. We're in a unique position as a 340B pharmacy to kind of help with high copays and uninsured patients. We can offer them sliding scale. We have grants and those types of things. So we can help supplement some of our patients. But it's hard because those ones that are at just above that level, trying to find the resources for those patients, I think I had one patient come in one day and she was just floored because she was $20 over a month to qualify for Medicaid. And it also put her out of our sliding scale for adjusting prices on medications for her. So, you know, working to find and fill those gaps where they're just above but yet still below, being able to afford daily life, to be honest, but even to afford their prescriptions and so forth has really been a challenge. So those are definitely some of the things that we're seeing in our community.
Thank you so much, Amy. Thank you so much, Amy. I think you're just echoing what Leslie, Amanda, and Sharetta said. Like, you're just reinforcing that gap that we're seeing, and we have to be intentional about addressing these challenges for our population, particularly our culturally diverse population. Marina, please.
Yeah, I would second that. I definitely would say that language is definitely a barrier. Finding a really good interpreter can be challenging. There are certain languages that, you know, since I do work with predominantly refugee and immigrant populations, sometimes you can't find them, they're not on, so that can be also challenging. I think another thing is as the refugees are arriving, for them to figure out how to navigate our health system, trying to figure out where is their pharmacy. Oftentimes they don't know. They know they're supposed to get meds, but they have no idea where do I go to even get it, right? So there is, I would definitely say, a lot of challenging housing. I think you guys all talked about that. That's definitely also, I would say, a challenge that we're dealing with. Mental health, you know, for certain cultures, you know, it's a taboo, still a taboo. So in this country, they don't want to take medication, you know, saying things like, but I'm not crazy, you know. And as I continue working with them, I think they open up a little bit more, you know, being able to kind of ask open-ended questions and just kind of being client-centered and trauma-informed.
Awesome, awesome. Yeah, so what you said actually was one of the questions I have on my list here. And I want us to learn from each other. The goal here, and I want us to be intentional, is that we're trying to learn from real life challenges and best practices. And I want to ask you, what are those questions, those open-ended questions you as healthcare providers, I'm coming to you too, Leslie, Sharetta, and Amanda, what are those open-ended questions you use to help your patients kind of communicate with you? What are those strategies you use? And I don't want to keep it to open-ended questions alone, but what are the things you've done that has helped you kind of build that relationship? Because one thing that was consistent was relationship building, so they can trust you and you can be able to support them. And so, Marina, you mentioned it, so I'm going to go back to you to say, how do you do it? What do you do? And then Amy, and then I'm coming back to Amanda, Sharetta, and Leslie. Please go ahead, Marina.
So I would say, you know, as you start working, let's say you get a client, you get a referral, depending on their culture. I speak Armenian and Russian. And so anybody from those countries, obviously, I'll be able to speak their language, right? So I have the cultural understanding. But I think any other cultures, if you don't, my suggestion always is, if you don't have a lot of understanding, do some reading up beforehand. Do some research before reaching out to a client to have a little bit more understanding, maybe what it is for them about the medication in their culture, right? This is the westernized medication versus whatever they're coming from. And so as you start working with them, if you already have a little bit of that information, that is helpful, how to kind of start asking questions and just kind of be open-minded as well. I think it's very important, and their belief system as well. So as I work with clients, I just let them explain to me what it is for them. If we're talking about just medication, let's say, what it is for them in their culture, how are they perceiving this medication, you know, versus now they're in United States and now they're let's say the provider gave them like, I don't know, like 10 medications they have to take, and they're just like, whoa, like, why is it so much? And in my country, I wasn't even taking that much. What's going on? So there is a lot, I think, educational, I feel like, piece that needs to happen. One thing I would add that's been working actually successfully is at Meade County, when a client would meet with a pharmacist, like one-on-one in person, not over the phone, right? So the interpreter would be also in person. I often, prior to COVID, would attend those appointments. So I would be present and I would hear all of that, and where the patient was able to write it down on a bottle in their native language. What is the medication for? How many times do they have to take it? So I think it's very challenging to do that over the phone, especially when it comes to medication, when they can't read the label or they're unable to read in English. So I think the key is to be open-minded, to ask questions, and just be non-judgmental. So that's technically for the past more than 7 years that I've been working at CareOregon, and in particular at Meade County. So that's been kind of my approach.
Thank you so much, Marina. Amy.
I kind of circle back to that. I think a big thing is to not come in with assumptions or thinking that even if you have kind of read up or studied on the culture, that you necessarily understand everything or what that particular circumstance is for that patient. I think as pharmacists, we're taught to be educators and learning to take a step back and kind of ask about what, like she was saying, what the patient's understanding and stuff is, or even what their routines are. We had a patient, we couldn't get their blood glucose under control, kept throwing medications at them, swore she was taking it, and we just learned to ask what her routine was, and we learned that she wasn't taking her night medications because her husband was a farm worker. He went to bed at 4 o'clock in the evening. It said take it at nighttime. Her medication was kept in the bedroom, and she couldn't go in after he went to sleep at night. So she thought if she was supposed to take it at bedtime, but she couldn't go in there to take it because he was asleep, she was skipping those doses. So we learned how to adjust and have asking her about her routine and how she was doing things and understanding her lifestyle and learning to match, medications or education to match what her lifestyle was. So.
Wow, that's an interesting one, because in some cultures, that's respect in terms of you don't want to wake up your partner because he's the main provider, and intentionally just waking him up just messes up his whole schedule. And so in that culture, that's so important. Yeah.
And it seemed like such a simple thing to just have her move the medications out of the bathroom in the bedroom to the kitchen or something, but that's just where they always kept it, and it just wasn't something that, so yeah, just kind of being open-minded and kind of following through what their day is like instead of just making assumptions on how their day is or what they're doing.
Interesting. Yeah, Amanda and Sharetta, please, I want to hear your thoughts on this as well. And Leslie, yes.
Yeah, I think meeting with a community health worker or a social worker who can sit down and maybe take more time to ask questions. And if these questions could be asked in a medical appointment, that'd be cool too. But some of those are like, who's supporting you take medications? Maybe it's your son 1 week of the month and then your daughter the other 3 weeks of the month because they share caregiving role. I think how consistently somebody's taking medication. Sometimes I work with patients who take a medication for 2 months, and then they have a family member who goes to Mexico and can get it for a lot cheaper and brings it back. And so there's gaps in when they take medications. And so, I don't know if the healthcare system can work with that, but some patients are getting medications from home country because it's so much cheaper. And especially for seasonal workers, they really have to budget around when that work happens and if they're going to be able to afford those medications. What happens? You run out. Is the patient calling to get a refill? Is their son calling to get a refill? Is another family calling to get a refill? Is there a plan? And then also location of pharmacy. I think a lot of patients I work with live in many different households, not just one house. And so how does the location of pharmacy affect their access? And then going back to social determinants of health. Do you need a bus ticket to get to the pharmacy? I think just some of those kind of basic needs questions often are just left out because, again, it goes back to the assuming that somebody's going to get this for you. Mm-hmm. And that's always the case. Mm-hmm. So those are questions I like to think about.
Mm-hmm. All right. Who's going up next? Leslie or Sharetta? I think Sharetta wants to go next. That's fine.
I'll even take it back even a step further. I think just not being in a rush when you go in, when a patient goes in with their appointment with their doctor. Things that I hear some of them say at times is that like the doctor didn't even like look at them or talk to them during their appointment, so they don't make it personal, and so the patient feels like, okay, all they did was type on the computer and wrote me out a prescription, and then they were like, as if that's what they came in for, was just a prescription. And so that person didn't get the prescription filled because they felt like that's not what they really wanted. They really wanted something else. Maybe the touch from the doctor to say, maybe this is a sprained muscle, not that they were looking for any pain medicine or something like that. That they've gone to the ER at times and they've gotten a list of medications from the ER to go get filled. And some of those medications on that ER discharge papers, medications are not covered under their insurance, and so they're not able to get those filled, and so they have to take it to their doctor, which then the doctor goes, well, we're going to send you to physical therapy for this because of this is something different. So then you have two doctors, an ER doc and then your primary care doctor, having a different plan for you. And that medication is another issue. So what medicine are you going to give me to take? So this is what I hear. And so as a patient shares that stuff with me, they're feeling like they're just pushing pills on me, and they don't feel like their health is taken seriously from that doctor or those doctors. And so then how serious are you about the medication that you're giving me? So they don't want to, they don't take it. And so it's almost like sometimes they feel like some of the medical providers feel like they don't know, they don't have a brain, and they don't think they can think for themselves and not put two and two together, and or something like that. And so they're like, I'm not dumb. I know what this is. I know what's going on. And so, or they go to the pharmacist and the doctor explains why they're giving them this medicine, but then when they go to the pharmacist is telling them what this medication's for. And sometimes the medicine can be used for two different reasons. That's confusion for that patient. And so then they go, oh, the pharmacist said it's this, and my doctor said it was for this. So, that's what you hear. And then you got to go back and try to figure out that. So those are some of the things that I hear from patients. And that's confusion. And that's challenging for them to be able to take the medicine. And the world. Yeah.
Thank you so much for that. I hear patient-centered communication in this, ensuring that our patients are involved, that they know, and they have that. They're human beings. Every human beings, healthcare provider, members, patients, they want a personal touch. Just one look in the eye just says, I care about you. I'm not just, just another checkbox for me to keep this time going. And we need to show that empathy to our patients.
Yeah.
Leslie.
So the challenge that I face often enough is around pain management and prescribed medications to deal with pain. And what then sometimes happens is it doesn't address the pain, how the medications are being prescribed. And folks are saying, we need to bump this up. I've got that kind of pain. And there's also kind of what Sharetta said, when people come in and they think that they're opioid seeking, but they just want relief from the pain. And sometimes, they're using cannabis because, that helps them to deal with the pain. It also helps to deal with the anxiety and the frustration and all that comes with not being heard. Because there are people that say, I am in pain. I've got back pain, I've got knee pain, I've got neck pain, compartmentalized pain. And it's like living with pain every day takes its toll in so many different ways. And so how that gets addressed can be very, very challenging for melanated people. That's been my experience. And I understand the opioid epidemic is out of control. And I respect that. The doctors have pulled back, but for some folks, I don't know what the recourse needs to be because they have that level of pain. I'm talking about pain from cancer that's mastitized, compartmentalized pain, severe sciatica, those kinds of things, and how those things get addressed when they call me and tell me, Leslie, I'm in pain. And all I can say is, I hear you, and I'm sorry that you're dealing with that, but that really is a situation that you have to deal with your provider. My hands are tied. There's nothing I can't even advocate for you around that, outside of saying the patient called me, once again, and they're still talking about the current regimen is not working for them. But that's about as far as I can go. I mean, that's as far as my advocacy can go. Especially when a person has a flag on their chart. And it can get really, really twisted and very convoluted, and very challenging for the patient. And then they call me to commensurate and for that empathy and that understanding, but there's still nothing that I can do. Absolutely nothing. The other thing that I always try to tell patients as I deal with them to try and get them to feel more comfortable, not only with me, but also with their provider, is to tell them off top, I need you to be straight up with me. I do. I can't help you if you're not being straight up with me. You don't have to front with me. Everybody has a life. Everybody's lived a life. I just need you to be straight up with me so that I can help you to the best of my ability. So you don't have to put on pretense. And I always tell people, don't let this look fool you, because I've had a life too. So with that being said, I've been accused. It's sometimes very challenging when I'm dealing with melanated folks, and they assume because I'm in the medical field, and I don't know if it's the presentation or the way that I speak or whatever, they think that I'm a puppet. I'm an emissary. I've been sent out to, I'm the white man's emissary. I'm like, no, you got me so messed up. And I still have to be professional, but sometimes I want to break it down and really let them know that that's not who I am. That is not what you see is what you get. I don't change regardless of what arena I'm in. This is who I am. Period. This is me. And and I also tell them, I said, never be afraid to ask a question. This is your life. This is your health care. You know more about yourself in many instances than what the provider does. If it doesn't feel right, don't be afraid to say so. You're learning every day about your body as your body moves and changes and does what it does. So when you feel that something's out of sync, you need to say that. And, for folks where English isn't their primary language, I really discourage them from saying yes all the time. Don't just go in there and say yes. If you really don't know, don't say that you know, because yes means the doctor thinks that you understand when in fact you could be totally completely clueless. It's okay not to understand. It's okay to ask a question. It's okay. Because nobody knows everything. So this is about your life. So you have to ask those questions when you're dealing with the doctor. And then they'll call and ask me, well, Leslie, what about? And I said, I can only go so far. I can only go so far with you. And then I have to reroute you back to your provider. But at least I can give you some tools in terms of how you need to communicate with them differently. And that's kind of where I plug in. So
Thank you so much. Yeah. Thank you, Leslie. We are running out of time. This conversation can go on. I'm learning a lot myself just listening to every one of you because your perspectives are rich, are robust, and they're just real. And I really do appreciate it. But I want us to end with a success story. I know we've highlighted challenges, and I believe that people have learned so many things, but I want to hear a success story. If you have any, just one or two from any of you that you can share in just supporting, our culturally diverse population and just one or two success stories.
Well,
Anybody?
I'll tell you one. The
All right.
lady that I was telling you about the toolbox,
Yeah.
she's doing great. In fact, she's doing the the medicine that comes in the bubble pack. She's using the bubble pack for her medicines now. Her blood pressure is doing well. Her diabetes is doing well. I mean, she's just a whole new person. Her children, one of her daughters have moved out, so that social determinants of health, as far as the pressure of mental health, dealing with her kids, were really taking her down. But she's just doing health wise, she's doing really good, and she's still at her same job where she was falling asleep at. She's not falling asleep anymore. So I mean, it's been a journey for her. I'm saying a few years for her, but she's doing a lot better now. So to me, that is a very successful story. And I started off with that, sharing where she was, but I'm really glad you asked about a success story because I really want everybody to know that she's really doing well.
All right. Thank you so much, Sharetta. Anybody else has any, and no pressure. So, Amy, if you have one, Marina, just share, but no pressure. It's just to round up on a good note because yes, we do have challenges, but I know we also have successes, and we want to make sure we highlight that as well. Yeah.
I can share one.
story. Oh, go ahead.
Go ahead.
I started working with a gentleman 6 years ago. At that particular point in time, he was homeless and he was an alcoholic. And he had a very significant stutter and was in a very heavy accent and was very self-conscious. It was one of those types of things when he would call people say, I didn't understand anything that you said. So the combination of the accent and the stutter made him very uncomfortable with relaying information. There's also a challenge with literacy. And when he would come, when he would come into the office after we got comfortable with each other, I would ask him, "Are you tired yet?" And he would just look. He would just look at me. And he would come in. I mean, soaking wet, smelling mildewed. And we would sit up and talk, and I would address his issues. But every time that he would leave my office, I would say, "Are you tired yet?" And he never answered the question. Never. So it took 5 years for him to make the decision that he was ready to put the bottle down. 5 years for him to decide that it was time for him to come off the street. I was able to get him into treatment. He was able to go with Central City Concern, started working, had actually been a welder by trade, but the technology had shifted all that. So he wasn't able to go back into that field because it was a hands-on thing for him at that particular point in time. He got housed, he remains housed, and I got him into another type of job that is, a significant living wage job, where he's able to sustain himself as well as to send money home to family. So, and he hasn't backslid. He's still keeping his head above water and doing his thing.
Awesome.
And I just recently got him into an English class. So he's ready to start learning English. And so, he makes my heart sing. He really does, because that was a long road. But he's doing all right.
Okay. Yeah, awesome. Thank you, Leslie. And Amy, will you give us the last success story, and I'll hand it over to Paul. Thank you so much.
Well, that one got my heart. So we had a patient. Patient was a patient with diabetes, and started coming in for appointments, and his diabetes was completely out of control. Couldn't figure out what was going on. Was picking up prescriptions on time. No issues there. We found out that he'd been displaced by the fire and was basically couch surfing or sleeping out on the sidewalks. So he didn't have safe places for his medications, particularly his insulin. And I feel like it's a success story because we were able to start deliveries to him. We did once a week deliveries. We broke insulin boxes and got them into a bag with ice packs and stuff. But we also started partnering with our CHWs on site to figure out what we could do to get him into some type of transitional housing. And we were able to get him into a transitional housing that had a small little itty bitty fridge in it, but it was enough for him to get at least 2 weeks of medication at a time. And CHW started working with him, and I'm sure other departments within my clinic, but within, I think it was about 5 months, he actually had secured another job and was looking to be able to move up to Portland on his own and was doing much better with his diabetes. But it helped build a bridge within our pharmacy and within our clinic where we started really starting to understand the importance of sharing resources and communicating with each other what we could offer our patients and how we could work together to help our community as well. So it felt really good.
Thank you so much. That's a beautiful story because that's a collaborative effort. It wasn't just focused on medications. It was that holistic approach that we all emphasize. Social determinants of health plus your clinical care makes you, improve health outcomes. So thank you. That was a great way to round up this section. And I believe Paul is going to take over and he has some questions for us, for you guys. So I'm going to hand it over to Paul right now. So thank you so much. I really do appreciate you all for being here today. Yeah.
There's a giant crowd of Oyinda's fans outside of the presentation room here, banging on the door. I think you're done a phenomenal job here today, my friend, of putting everyone together. Everybody on the panels, I just can't thank you enough for spending time with us here today. But a lot of folks have asked a few questions during the chat. I wanted to just make sure we got a chance to pitch a couple of them out here just to see what your take on these was. This one was really interesting because we talked about combination drugs briefly during one of the earlier segments. And this question was that we see so much clinical bias against prescribing combination drugs for hypertension. What are some ways to overcome this reluctance and this clinical bias?
I will say I think some of the struggle there is that oftentimes, not all of them, but oftentimes the combination drugs are harder for providers to dose adjust. So if somebody's not stabilizing, sometimes it's harder to figure out which component of it is. So maybe educating providers on different things that are out there, different strengths. And also, a lot of times the combination medications, particularly when they're newer, are not covered. So it's actually much cheaper for patients. Unfortunately, it's a bigger pill burden, but a lot of times it actually is more expensive for patients to get combo products than it is to get separate medications.
Wow. Yeah, I don't think a lot of folks are realizing that. I know I didn't on here. And this one was, I think, more of just a comment. I think kind of echoing what we've heard a lot of you talk about. But this person mentioned that a lot of patients that they see discharged from the emergency departments with paper prescriptions, and they can't afford to get them because they're underinsured or uninsured. And how do we go about that? That's just such a monolith of a problem. But I want to try to cut a couple of these up here. There's a lot of just things came through the chat that aren't so much questions, but folks just really appreciating the work that everybody is doing, especially getting the chance to hear from community health workers and find out what you're experiencing. And so let me pitch this one to all of you. This question was, how do we help support community health workers? How do we help continue to elevate this conversation?
I will say, I'm talking a lot, sorry, but I will say, coming from a retail pharmacy background, I didn't even know what a community health worker was until I started working at an FQHC and an in-clinic pharmacy. I don't think a lot, as far as pharmacy goes and things that are available for patients outside of copay cards and GoodRx, I don't think our pharmacists out there, particularly in the retail setting, know what resources are out there. So somehow educating maybe our pharmacists and other clinicians out there, even what a CHW or a community health worker is, or what resources are available outside of just the standard things that they're used to, prior authorizations, etc.
Mm-hmm. Definitely education, educating the public on community health workers. I don't think anybody really knows about traditional health workers. So I think the support would come from just educating the medical field around it, that we're here. And there's a lot of us. There's some people who are traditional, they're community health workers. It's really like giving the title to what people do every day that don't even get acknowledged for it. You know what I mean? Kind of thing. So.
No, I think we've been lucky in that the profile started to get illuminated a lot more over the last couple of years. But
yeah,
for a while, it was certainly like, what is that? And and a lot of confusion. And now it's like there's a lot more focus and a lot more requirement to focus, which is great. Someone brought this up in the chat too, and I thought this was kind of encouraging. And I think we've heard a little bit about it, but I wanted to put some more focus on it in terms of just the efforts that happened with legislation that was called the SMART legislation back in 2019. Safe medication for all requires translation, SMART, right? And that requires pharmacies to provide dual translated medication labels in at least 14 languages. It doesn't sound like that law necessarily is going to include money for outreach. And a lot of prescribers and pharmacists and folks like all of you are going to need people with non-English preferred language assistance. And there's also, I think, a requirement for labels to speak to persons who are visually impaired, and that kind of echoes off of what Dr. Uche was talking about when she was talking about what about after visit summaries that aren't written. So it's something somebody has to hold on to and then be able to read, but something that can actually speak to them. I mean, I think those are encouraging ideas, and I hope we are able to see them implemented successfully. Do you think there's enough awareness about this that's going to change, though, that this is on its way?
Amy, do you think there's awareness? Because I know there's been some pushbacks from our pharmacists in terms of coverage and cost of this, but I know our pharmacists are aware, our pharmacists are aware. But I also want to hear from Amy. Amy, you are in the thick of this, so I want to hear from you.
Yeah, I think as far as pharmacy itself goes, we are definitely very aware. We're not only having to provide the labels in dual languages, but we are also having to provide any education that goes with those prescriptions in dual languages as well. So it doesn't just stop with the label. I think what the problem is, though, is that it stops with pharmacy. I don't know that it goes, either direction, as like you were saying, like the after visit summaries and stuff like that, the continuing after that of not just getting that prescription. And again, it is a hardship. I will tell you the software and the supplies to accomplish this for the pharmacies is pretty extensive. Everything that we have to put on a prescription label to include dual languages, the bottles need to be almost about this big now to include everything that has to be on there. Also, the language is dual language on there, but the color and description isn't necessarily in dual language. So there are still some very big gaps in there that haven't been addressed yet. And there definitely is a financial barrier, I think, from it going anywhere else. But the Board of Pharmacy has definitely taken this very seriously, and there is huge oversight for us on this. But I don't know, as far as the rest of the medical field goes, how far that'll go.
Well, it's going to be interesting. I think we're going to hear a lot more talk about that and a lot more focus for sure in the months to come as that starts to become more widely known. We've had a lot of really great comments today from folks in our chat, and there's no way we're going to be able to squeeze them all in here today, but I wanted to just make sure that to thank everybody for sharing. The conversations that we all were able to have in these panels were wonderful today, and we feel like it's really just the beginning. And I would expect us to have this is like the second in a series of these equity-focused conversations that we've been trying to generate here, and I would expect us to have more of those and build on this, particularly when it comes to the role that pharmacy can play and how we can better engage around medications for folks in more impactful, more personal ways. I think that's really key, and so we're really hoping that we can continue to bring folks in and build on this as we go. So it's pioneering stuff going on, but we're super excited to be able to include everyone in these conversations and give folks a chance to hear what they're seeing and what's going on. It's very grateful for everyone's time, and I would expect you to be bombarded with contact requests when we're all done here today, because I think a lot of folks are going to want to continue to avail themselves of your expertise. So thank you. And not just for joining us this morning, but thank you for all the work you're doing. It's just incredibly impactful, and I think it's rare to be able to feel that the work you're doing makes a profound difference for people. But I think all of you joining us here today can definitely feel that feeling every night. So it's just you're making a tremendous difference for people, and world's a better place because of the bright lights you're all shining. So thank you, especially in these crazy times. So for all of our attendees who are still with us today, just a couple of last little bit of housekeeping things. I know this is always a very popular question that comes up as far as how do I get my certificates for attending here today for CME or CEUs, whichever the case may be. Anyone who signed up to this session today through Eventbrite's going to have we'll have all of your email contacts, and we send out a couple of different surveys for you, depending on whether it's a conventional CME credit you need or more social worker CEU credit hours, either one. So there'll be two different surveys. The email I send will make that super clear and super easy. So it's a short attestation, just to give us a little bit of feedback, very, very brief. And then everyone who responds to that survey, I will be sending out your certificates. So you'll have those in the next couple days. So worry not, and let me know if you don't receive any of those emails. So sometimes they do go to spam or junk folders occasionally. So don't worry, but we'll make sure to get everyone taken care of. Want to extend massive thanks to our moderator, par excellence today, Oyinda Osibanjo. Wow, phenomenal job. And just to bring all this together and to be able to get people to open up like that is no easy thing. So thank you, my friend. And to all of our participants today, all of our panelists, all of our clinician presenters and community health workers, we're so grateful for you. I just want to mention briefly, we're kind of trying to do as many touch points for education between now and the end of the year as we can. And when I send out the slides, you'll be able to use those links to enroll in our next upcoming classes. The one we're doing in November, creating a gender affirming environment and updates on hormone therapy. We are lucky enough to have presenters from OHSU's Transgender Health Center, including Dr. Christina Milano, that should be able to join us for that. Should be a phenomenal session. And then we're going to be doing a December refresher, trying to unmuddy the lake of pharmacy benefits so that are a little bit more clear and easy to understand, because that's something that folks always have questions about. And so we want to do everything we can to make that easier to understand for folks. So, and I think, did I see one hand that was still raised here that I did not get a chance to acknowledge? I'm trying to see if I can get that chat to show up here. But I think it may have popped out on me. I'm not sure what happened. The hand went down or something. So apologies. Email me if there was something that you didn't get a question answered. I'm happy to try to help you all there, folks. That's it for today. It is the bottom of the hour, folks. I want to thank you all again for attending and for all of the participation we had today to make this robust discussion as impactful and engaging as possible. And to all of you attending MedZed, thank you for all the work that you do to improve the health and lives of so many Oregonians. We are profoundly grateful for you all. Have a wonderful morning, and thank you so much for coming today. We will
Thank
see you
you.
soon. Be well.
Yeah. Bye, everyone.